Greetings. My name's Corey Langer. I'm the Director of Thoracic Oncology at the Abramson Cancer Center in the University of Pennsylvania in Philadelphia. And it's my privilege today to be joined by Karen Reckamp, Division Director of Medical Oncology at Cedars-Sinai. So a bi-coastal discussion, and in this case of de novo EGFR resistance with a focus on Exon 20. So I'm going to put you on the spot, Karen, actually bring up a couple of cases and see how you would handle them, whether you did the same as I have or would have done something different. I don't think there's any right answer here, particularly when we're dealing with mutations that are intrinsically resistant. First is a 69-year-old woman, never smoker, faculty member here at Penn. History of MAI, fairly severe Mycobacteria aviae intracellularity. She's required 3 separate oral antibiotics, chronic cough, some dyspnea, fortunately not O2 dependent. She developed a new mass in the left upper lobe that did prove to be adenocarcinoma. And in July of 2017, she underwent resection. She had a left upper lobectomy, as well as a left lower lobe wedge resection and node sampling. Pre-op, her CT and PET were negative in the mediastinum, but there was a surprise N2 node, level 5, so she was staged at 3A. She received 4 cycles of adjuvant cisplatin PEM through the end of 2017. She also received, well, she was considered for post-op radiation, but because of her MAI, that was deferred. And I think in retrospect, given the recent results of the lung ARC trial, that was a wise move. She was worked up for the Alchemist trial, and she actually underwent molecular testing. And internal assays here, at least, proved positive for a de novo resistance mutation, Exon 20. She did well for about 3 years, but in September, she developed multifocal pulmonary nodules. It was awful tough to differentiate these nodules from her background MAI. She had always had tree and bud abnormalities that waxed and waned, but these were new nodules that had a different morphology, and they were clearly growing. And ultimately, we biopsied one of these nodules on the right lower lobe. It was about 1 centimeter in size, and it recapitulated the original histology. It was adenocarcinoma and, in fact, harbored the same exon 20 resistance mutation. So how would you handle such a patient? She's pretty healthy except for the MAI. She's fully functional. She's still working, still doing research, is on a number of antibiotics chronically for her MAI. Without these, her pulmonary function deteriorates. What would your approach be here?
Just for my clarification, her pulmonary function is okay, or she's symptomatic from the MAI?
Modestly symptomatic. Her pulmonary function is not perfect, but it's she's not requiring oxygen and she can walk about, although her chief symptom is cough.
So the MAI definitely complicates things, and this is a patient, she got chemotherapy 3 years ago, so you might think about chemotherapy again, but with the MAI and potentially not wanting to immunocompromise her and make that potentially worse, I think looking at alternative options would be ideal. We didn't talk about whether she had high PD-L1. Again, we talked about in our previous podcast, we talked about patients who have EGFR mutations and high PD-L1 that don't have the response rate for PD-L1 inhibitors alone, or PD-1 or PD-L1 inhibitors alone, are less than 5%. And so regardless of her PD-L1, probably immunotherapy alone would not be the best option. And active MAI, I think, also makes immunotherapy a challenge.
For sure.
So I'd be looking for a trial for her for something with mobocertinib or amivantamab. But outside of that, again, there are some descriptions of using drugs like osimertinib in these patients, but response rates are still pretty low. So I don't envy your challenge with this patient.
Unfortunately, her active MAI precluded her enrollment on a clinical trial.
Right.
She was requiring ongoing antibiotics. And, this is not uncommon. We have patients, we tee them up for a clinical trial. We think they're excellent candidates, but lo and behold, they can't go on. So I actually did use osimertinib. The data had just come out. Zosia Piotrowski presented this, I think, at ASCO, maybe updated it again at ESMO, but response rate, as you pointed out, wasn't terribly impressive. It was about 20% or 24%. Disease control rate, though, was fairly good, so stable plus response I believe was about 80% or higher. And the median PFS appears to be 10 months. Now, mind you, this is double dose OC. This is 160 milligrams, not 80 milligrams. But amazingly, she's tolerating that a lot better than she ever tolerated her MAI drugs. And in fact, it's just 2 months into treatment. Her disease is responding nicely. She's had about 60% regression. My big question, of course, is what do I do when it stops working? And there, I think ultimately probably will default back to chemo unless some other agent gets approved in the interim, unless you have better ideas.
I don't have better ideas than that, but she's going to need a lot of TLC for sure.
Yes, definitely. I have another patient. Again, these are real life patients. This is a 76-year-old gentleman, former smoker, but remote, less than 10 pack years. History of mild interstitial changes at the bases of his lungs, no real pulmonary dysfunction to start with. Underwent a video-assisted thoracoscopic surgery and resection, left upper lobectomy for a fairly large tumor, 8.5 centimeters, with acinar and papillary features. There was lipidic growth and some lymphovascular invasion, but no discrete nodal involvement. All intraparenchymal, hilar, and mediastinal nodes were negative. He too received 4 cycles of adjuvant cisplatin pemetrexed, was observed, but didn't go for very long before he had a recurrence. About a year later, maybe 13 months later, a routine surveillance CT showed fairly pronounced micronodular infiltrate in the left lung, which at first we thought could be infectious, but he failed to respond to antibiotics. The infiltrate got worse, and bronchoscopic biopsy actually confirmed recurrent adenocarcinoma. We did molecular testing both on the original and subsequent path, particularly in light of his remote minimal smoking history, and here too we detected EGFR mutation, Exon 20, one of the resistance mutations. So this is a man who's otherwise uncomplicated, does not have intercurrent infections, is actually in phenomenal shape. He golfs at least twice a week. He looks quite a bit younger than his 76 years. How would you approach this individual?
So again, this is a patient who got chemotherapy a little more recently, but I think it was maybe over a year when the patient progressed, so potentially going back to chemotherapy. But again, this grew despite the adjuvant chemotherapy that he received. And I think we're going to similar types of conversations outside of a trial. You could try high-dose osimertinib, might be less tolerable in a person who's in their mid-70s. And hopefully looking at trials would be the ideal option for this patient.
And in fact, Karen, he did go on a trial. He actually went on the mobocertinib trial. We didn't have it open here, so I had to refer him to one of our colleagues on the East Coast. And miraculously, he has been on mobocertinib since 2017. I think he may be an outlier, at least in terms of the trial. He's had a fair amount of toxicity, developed peripheral edema, rash, xeroderma, mouth sores, diarrhea. He had sort of cold intolerance and at least initially lost a bit of weight. He needed dose reduction, but then finally stabilized with the help of both the dose reduction and also some brief course of steroids. And over time, his side effects pretty much resolved. Again, he's resumed golfing. 2.5 years into this regimen, he's in a near CR. He still has some small micronodular densities on the left side, but they're at least 80 to 90% improved, and it's been pretty impressive. Again, I'm waiting for the other shoe to drop, but certainly his progression-free interval far exceeds the median on this trial. I think it was about 7 months. Correct me if I'm wrong, but remember the medians are midpoint. It's 50% of folks will be beyond the median, and it's certainly your goal and my goal to get our patients beyond the median if we can. But any other thoughts about de novo resistance, Exon 20?
Well, I think the point that you talked about with the long list of toxicities that he had and that he was able to overcome it, to me, that's the key. My experience with these drugs is that the toxicities are significantly more, especially at the highest doses, than what we see with erlotinib, afatinib, gefitinib, and osimertinib. And so when we say it's rash and diarrhea, it's actually a little bit more than that. And patients often do need things like steroids and a lot of supportive care to get, and then a little bit of dose reduction to get them to a place. But the fact that he was able to stay on the drug, some of my experience is that we couldn't keep patients on the drug because of the toxicity, or they were taking too many breaks that we couldn't maintain that response. So keeping the patient on the drug at a tolerable dose with a regimen that was helping the toxicities, I think, is some of the key to the success of utilizing these newer oral agents.
I agree wholeheartedly, and typically above and beyond protocols, we'll schedule a toxicity check 2 weeks and 4 weeks when we're starting a patient on a new TKI. And I think, as you point out, with these newer agents that are potentially a lot more toxic than osimertinib, at least in EGFR, and then alectinib and ALK, they need a higher level of vigilance and follow-up. But TLC is definitely part of the regimen, not just the TKI. So 2 Ts, TLC and TKI. This has been fantastic, Karen. I think we've reviewed the length and breadth of de novo exon 20 resistance. And again, for all of you who are listening in, thank you very much for your attention.
Thank you.